right, why don't we get started? I don't want to make those that have joined us wait any longer. So I just wanted to say hello and thank you all for joining us tonight. My name is Alex Schulp. I'm a territory manager with Inspire Medical for the north and northwest suburbs of Chicago. And we're really excited tonight to have our presenters from the Ear, Nose, and Throat Care Center in Barrington. Dr. Jason Cundiff and Dr. Gary Livingston are here to tell us a little bit about Inspire therapy for obstructive sleep apnea. So there's a short presentation, and then following, we'll have a question and answer segment. As we go through the presentation, if you have any questions, don't hesitate to put the question, type it into the Q&A box, and we'll make sure we address it at the end. And with that said, I'll turn it over to Dr. Cundiff.
Great. Hello, my name is Jason Cundiff, ear, nose, and throat doc. I've been practicing in the Barrington area for about 16 years, for those of you who don't know me. And I just want to start by thanking everybody for taking some time out of their day to learn a little bit about Inspire, which we are really excited about as a new innovative way to treat obstructive sleep apnea. Go ahead, let's go to the next slide. You know, as physicians and healthcare workers, you know, this is something that we're all very familiar with. Obviously, there are multiple consequences to not treating sleep apnea. There's, you know, certainly the things that the average patient's aware of, you know, the snoring, the fatigue, their increased community risk with car accidents and so forth. But I think the thing that I really want to stress is just the health consequences that go with untreated obstructive sleep apnea, hypertension, stroke, diabetes, heart failure. We really, there's a lot of people who are out there who we are not addressing appropriately. And it's really important that we, you know, try to help these people deal with their obstructive sleep apnea. Next slide, please. So again, I think we're all aware that, you know, the frontline treatment for obstructive sleep apnea is CPAP, and we're not suggesting that that changes it. But the other thing that I think we're all well aware of is that there's a lot of people who really struggle with their CPAP, and the compliance with CPAP is really poor. And there's multiple studies that look at CPAP adherence rates, compliance rates, and you know, the Apple study in 2012 showed that only 40% of people were compliant with their CPAP at 6 months. And so these are the people that we really want to be concentrating on and who might be good candidates for Inspire. Next slide. So the Inspire therapy, it's basically a treatment for people who cannot tolerate CPAP. It's a safe outpatient, and this is kind of safe outpatient procedure, which we'll go through some of the details, which basically has a small implant which stimulates the hypoglossal nerve and allows the tongue, prevents the tongue from collapsing in the airway. There's a remote that turns it on and off. And then we're able to get data to kind of moderate the efficacy of the Inspire implant. Next slide. So there's several studies, but the study that really kind of that we all tend to cite is the STAR study, which was published, and it's basically it was a prospective study of 126 people that showed very effective, basically showed how effective the Inspire implant is. And then the other thing that we've been seeing here over the past just couple of years is that now this has broad insurance coverage, which now is really making it accessible to our patients here in the community. So Medicare is covering this. Many of the commercial insurances are covering this. So this pathway to Inspire is really improved. Next slide. So this is that STAR trial that I was referring to. And so If you look on the left side, you can see at a 5-year follow-up, baseline patients had an apnea-hypopnea index of 29, and we have long-term data now showing that that by using Inspire, we're able to significantly cure them of their obstructive sleep apnea. And in fact, 80% of people who undergo Inspire will have resolution of their obstructive sleep apnea. And then on the right side, again, we're familiar with the Epworth Sleepiness Scale. And again, this just kind of goes to show you that people who use Inspire also not only do we resolve their, improve their apnea-hypopnea index, but we also improve their quality of life. Next slide. Has high satisfaction rates. 93% of people who are implanted with Inspire are happy with it and continue, are satisfied with the procedure. And adherence rates average of 5.6 hours a night. Next slide. So I'm going to hand it over to Dr. Livingston, who is our lead Inspire implanting surgeon here, to kind of talk a little bit more about the procedure and the process.
Thank you, Jason. We're pleased to have everyone join us tonight. Thank you very much. Pleased to be working with Inspire. They've asked us to partner with them to start the program, which we have at Good Shepherd. We've successfully done 6 implants now, and it's up and running. The sleep lab has the capability here at Good Shepherd to program the device, also Dr. Keller's office as well, who is able to care for those patients. So if you want to go ahead and start the slide, the patient has a remote control, turns on the device. It waits about a half an hour to kick in. That can be variable, but once the patient's asleep, the device senses the breath in, stimulates through the generator in the upper chest to cause the tongue to protrude forward. When we implant the device, we selectively stimulate the branches that make the tongue go forward from the separating those from make it go back. So that opens the airway. It's a very proactive way to open the airway. It's not like a CPAP machine that's waiting for that obstruction to occur to maintain the ventilation. A patient wakes up in the middle of the night, they can turn it off, turn it back on, wake up in the morning, and go about their business. So what does it look like when you look at the airway? Lower left side, you see the motion of the tongue base. The part at the top of the screen is the back of the throat. Tongue base is at the bottom of the screen. And you see likewise the palate is quite collapsed. This is a view from above that you'd see with an endoscope during sleep. And on the right side, you see what the airway looks like with the stimulation. The base of tongue moves forward. You can see part of the vocal cords that are at the top of the screen. And then on the right side, in the 2 slides on the right, you can see the palate actually moves with the tongue protrusion. So there's a coexisting motion that happens with the soft palate as well to open up that airway. The next slide. So what does the general pathway look like to get to the endpoint? We rely on our primary care physicians and sleep physicians to look at those patients, have a sleep study. We want a complete sleep study. It can be done as a home study. Then we want to see, actually have them try the CPAP. That's very important to have at least a minimum of a month, if not 2 months, for that patient to try it. It's easy for the patient to say, I don't want to use it, but that is a critical part of qualifying for this sort of treatment, is to at least go through a concerted sleep or a CPAP trial and have that documentation. If the patient meets the criteria, which we'll talk about in a minute, as far as the severity of the sleep apnea, between an apnea-hypopnea index of 15 to 65, if their body mass index is below 35, then they can have that initial qualification. That brings them to the second step, where we evaluate them in the office. The drug-induced sleep endoscopy is an exam, a very brief exam at the hospital in the endoscopy lab, where we give small incremental doses of propofol and simulate sleep and look at the pattern of collapse. And if the patient qualifies past that step, then they can go on to the next step to have the actual implant. The implant is done as an outpatient, general anesthesia. Most patients go home same day on some Tylenol for pain, and they actually don't start using the device for about a month. We want to let the leads heal. We don't want the patient lifting, straining, lifting their arms up over their shoulder for that initial 3-4 weeks. A month later, then they come back to the sleep physician who is going to do the programming and the monitoring, and then they set that up, and the patient then goes through a series of adjustments at home themselves to set the intensity of the device to the point where they have a comfortable stimulation, doesn't bother them, and they maintain a good night's sleep. Longer term then, 3-4 months later, typically there'll be a sleep study to confirm that. And then as Dr. Cundiff mentioned, there's in the newer monitors, the newer remotes, they can actually monitor the compliance so that entities such as Department of Transportation can monitor for compliance of use and so forth. The next slide. So as far as the eligibility, the age is 18 or older. There are actually some studies going on now with children younger than that for Down syndrome where that may benefit. The sleep apnea is, again, it can't be too mild, it can't be too severe, so that apnea-hypopnea index falls between 15 and 65. And that the tolerance of the CPAP, you have to document that. And these are patients that may have tolerated for years before sometimes they become claustrophobic or they can't breathe well through the nose. They become intolerant for that reason. But that documentation is important. You can't skip that step. The other important point is that study that we do has to assure that there's not a lot of central apneas. If your brain doesn't initiate the breathing, this device doesn't work. So it has to be less than 25% of combined central and mixed sleep apnea. The website, the Inspire website, has lots of interactive information for the patients. So all you have to do is refer them to that. We have pamphlets and so forth. There's excellent educational support by the company, but the website really goes a long way to help the patients understand. There are patient ambassador programs where they can actually talk with patients who've had the implant and get some more information, some more reassurance. If we can, next slide. So that drug-induced sleep endoscopy, you can see at the top slide, you can see how the palate collapses front to back. The back of the throat is on the top of the slide. And that's a favorable kind of pattern of collapse that we know is likely going to predict good success for the procedure. On the bottom, you can see that collapse behaves more like a purse string or it circumferentially collapses, and that would be a poor candidate. So about 1 out of 5 patients will have that sort of collapse and thus can't undergo the procedure. Generally very safe, very low risk of complications. The pain management, again, Tylenol typically. We check the wounds. We've now gone from, the FDA has just approved a 2-incision approach, and we've gone from 3 incisions to 2 incisions, which should shorten the time for the procedure and make the recovery a little bit easier, a little bit less painful. The battery, just like a pacemaker, lasts for about 11 years, and the entire device can be replaced. The critical part of the procedure is really the sensor and the stimulating lead, so the replacement of the generator is very brief and simple to do. And finally, patients can still obtain MRI scans. Up to the shoulder, they can have head and neck MRIs and extremity MRIs, but not of the shoulder, of the torso. Next slide. We have one of our early patients who had the implant and has had an excellent result. He's very enthusiastic. And so we'll play that for you now.
I had major issues sleeping, snoring, sleep apnea. So I'm in the construction industry, and you need your sleep. You work hard all day and you got to be focused, pay attention. We started with the CPAP, very uncomfortable, very restricting. It's almost suffocating if you want to say. I mean, for some people it works. For me, it was absolutely no way. My wife would actually sleep in the other room. So it was time to find something that worked. And that's what led us to the Inspire.
Inspire is this new innovative procedure for treatment of obstructive sleep apnea, specifically designed for patients who are unable to tolerate CPAP. It requires 3 small incisions, an incision on the neck and a small incision on the chest, and we implant a small pacemaker-like device in the chest with a wire that goes to a small nerve in the neck. This pacemaker sends a small stimulus to a nerve in the neck that stimulates the tongue and prevents the tongue from collapsing while we sleep.
When you press the button, it'll activate the Inspire, gives you 30 minutes to fall asleep. So you're usually sleeping already before it turns on. And when you wake up in the morning, after 8 hours of it being engaged, it automatically turns itself off. So yeah, it's a great tool. I'm so glad I did it. My wife's glad I did it. My wife is currently back in the bedroom, and yeah, she says everything's good, feel better now, and yeah, best decision I've made.
Do you have any questions from the audience, or?
Yeah, we do actually. So, so thank you both for going through that. And it looks like we have a couple questions from Dr. Salvi. The first being, if it's true that only 40% of CPAP prescribed patients are compliant at 6 months and 80% of Inspire patients are benefited by the procedure, why isn't Inspire first-line treatment?
I think Inspire loves this question.
That's right. You see me smiling.
Yeah, who knows where this will end up? I think it's, since we've only gotten really majority of insurance companies to start supporting this procedure here within the past 1 to 2 years, there's certainly some barriers towards, considering this as a first-line treatment. But yeah, I guess it'll be interesting to see where the evolution of this procedure goes. But yeah, I was pretty impressed as I started really doing, delving into the research about this, how poor the compliance is with long-term use of CPAP. Yeah, that's a great question.
Yeah. Followed up with, if a patient has the Inspire procedure and then doesn't like it, is bothered by it, or isn't benefited by it, can they have it removed? Is that removal process easy?
You wouldn't want to remove the stimulator lead and the hypoglossal nerve. You can leave that in. It really wouldn't cause any problems. You can certainly take out the generator, but the sensor lead and the simulating lead, I don't think there are more risk to removing it than leaving it in place. And they really aren't very noticeable. You don't feel them. They're well hidden. But even if it's not completely optimal, there's still benefit in this device, and you can augment the treatment with other modalities too. So it's not necessarily an all or nothing process.
Yep. And if I can add to that, so our explant rate is less than 1%, but I know I've heard recently a patient lost a tremendous amount of weight and didn't like aesthetically how the generator looked and had it removed very easily. So it's always an option if you'd like. Okay, next question. Could you again go over the home sleep study component? As a I guess, does it have to be a home sleep study before they're considered a candidate or not?
It can be in lab or home study. That doesn't matter as long as we get complete information about the, the apnea hypopnea index, the central apneas. Of course, you get more information as an in-lab process, but the home studies seem to be pretty complete these days. So,
and I believe a lot of these insurance companies are running sleep studies that are within 2 years. Is that right, Alex?
Yes, that's right.
Yeah. So So certainly we can, start the process and see patients who aren't tolerating their CPAP from older studies, but if from an insurance standpoint, again, we need to update their sleep study.
And then also, is having a cardiac pacemaker a contraindication?
No, it's we actually implant on the opposite side, so it is not a problem at all. You can scuba dive down to a depth of 100 feet as well if you would like to do so.
Okay, great. So since we have a smaller group now, I'll open up if anyone has a question that they want to ask live or again, type into the chat box. It looks like one more question popped through. What happens to the stimulation in the middle of the night when someone wakes up to go to the bathroom, especially if they have BPH and the patient wakes up frequently?
They can turn off the unit and just restart it when they're back to sleep. A lot of patients really don't describe a lot of pain with it. They feel, some movement, some pressure, but they don't describe a lot of pain. So most of them really don't describe it as, in fact, that's how they set it up. They will modulate the intensity of the stimulation, but they turn it off and just turn it back on when they go back.
But my impression is most people get so used to it, they just leave it on, go use the bathroom and go fall back asleep. It's not painful.
And we do have a pause feature, so the patient can pause the device, so it doesn't have to be turned off completely. And that's something when we activate the therapy in the sleep clinic 30 days post implant, we talk about with the patient. So we'll ask, how many times, what pause time would you like? We can set it in any 5-minute interval for them. Okay, another question came in. I had a sleep study, was diagnosed as extreme sleep apnea. I brought the CPAP home, have tried a few times and just can't stand the mask. Does the sleep study they did stand, or would a new one be required?
As long as it's within 2 years, it's okay. So it's current and it has, enough delineation of those parameters. So.
Yeah, again, depends on the insurance, but right, about 2 to 3 years is usually what's needed. Do you have to wait 30 minutes for it to turn on again? And that's following up to the pause or if the patient gets up through the night.
So if you hit the pause, no.
The pause probably is a shorter time to reactivate, I would think.
Yeah, our pause default time is 15 minutes, but again, it can be adjusted in 5-minute intervals. So if someone would like a longer or shorter pause break, if they get up, get water, go to the bathroom, and then have to fall asleep again, that's something we discuss with them and can customize when activating their therapy. Also, being a type 1 diabetic and a little nervous about any surgery, is there an added risk from the T1D?
We give one prophylactic dose of an antibiotic, so it's low risk infection is possible, but it's a very low incidence. I wouldn't, that's not a contraindication by any means.
So can the patient make these pause and delay adjustments themselves?
Alex, I don't know. Can they?
As of, no, they can't right now. I could take that one. So no, as of right now, that's something that they would have to come into the clinic because they have to bring their remote, and then we have the office in the clinic has a programmer that makes those settings. But in the future, the remotes will be Bluetooth, and they would have a conversation, through the portal or a phone call with their physician, their sleep physician, and then they could make those changes remotely. So today have to come in, but in the next 6 months with a Bluetooth remote, they do not.
Cool.
Do they carry a card for airport travel security as patients with cardiac devices?
Yes, that's given to them with the remote.
Okay, are there any other questions? So far, I've gotten all of them. One question I've seen is how do you set patient expectations or timelines for CPAP trial before recommending Inspire?
I think at least a month, if not 2 months. The insurance requirements are variable, but it's to be cautious. I think that it would never hurt to go a little bit longer, just to make sure that they can't come back in retrospect and say you didn't try it long enough. There's good documentation that we like to see the reasons why it failed. Is it because the mask leaks around your nose and face, facial hair? Some patients will say, I get wrapped up in the hoses and like a thresher shark in a death spiral, and they wake up, like a mummy. And so just getting as much descriptive information as to why it failed and claustrophobia and so on and so forth. But, I think at least a month, if not 2 months. So the more information we can provide, the better.
Great. And how do you handle higher BMI patients?
I think you can, talk to them about losing some weight. If you get down to the Medicare maximum BMI is 35, but commercial is 33. And so there's some latitude between those two numbers for commercial patients. But a lot of the patients, if they come in with a BMI of 38, 39, you're not asking them to lose tremendous amounts. You're giving them some realistic expectations that they can work with their physician to have a medically supervised program of weight loss that gets them to that point that they qualify.
Another question came in. Do you work with the other pulmonary groups at Good Shepherd Hospital?
Yes, we can take in patients who've had studies from anywhere outside Good Shepherd, outside the system. Of course, to use the device, you have to be able to program it. And if physicians are interested in other systems, other labs, that they can talk to Inspire about doing that if they feel that they have enough volume and interest to do that. But we can send the patients back for sleep studies and so forth to confirm with the primary group. But the actual programming has to be done through a qualified lab that has.
Yeah, we're excited to work with anyone. Just right now at the moment, the Advocate Good Shepherd Sleep Study or Sleep Center and Dr. Keller's Sleep Center are the two local ones that are ready to program the Inspire, but that's certainly, there's no limits to that. And so we have certainly have reached out to the other local sleep docs, and we're hoping to get as many people on board as possible.
And how do you work with your referring partners to set up appointments or communicate about Inspire?
We're happy to look at the sleep study. If the patient or the physician's office wants to send that over, we can look at the BMI, the sleep study, to make sure that things are qualified. And even in patients who've had a sleep study that's older than the 2-year time limit, if it's within reason, we can see the patient, do the drug-induced sleep endoscopy, and if they actually qualify, go ahead and just get another sleep study to meet those qualifications with a home study. And there are some exceptions where they'll still be able to use an old study if it's only outdated by 3 or 4 months. But we can start with the premise of the previous study, and as long as we follow up with an updated one. So.
Yeah. So I don't see any other questions coming through. I'll go forward here and provide our contact information. So you're welcome to reach out to myself if you would like any more literature or clinical data on Inspire, or to have your offices armed with patient education material. I also have referral packets for Dr. Livingston and Dr. Cundiff's office to arm with your patients who might be interested. And then also, of course, all the contact information for Ear, Nose, and Throat Care Center.
And I know everybody's busy, and I just really appreciate you taking your time out of your evening to listen to us and learn a little bit about Inspire.
Thank you very much. Thanks for joining us.
Have a good evening, guys. Thanks again.
Take care.
Thank you. Good night.
Thank you.